Good afternoon, everyone. I'm so excited to welcome you to this year's celebration of National Midwifery Week with Frontier Nursing University. Thank you for joining us. I am Dr. Noelle Jacobson. I'm the Interim Clinical Director for our Department of Women's Health and Nurse-Midwifery. We are so excited today to welcome you to listen to our honored keynote speaker, Pirtle Tyler PhD, MPH, brings over 15 years of experience advancing reproductive and maternal health equity. As a chief health officer at Rhia Ventures, she works at the intersection of reproductive justice and capital to translate the needs of the women and other birthing people most affected by systemic inequality into programming and services. Before joining Rhia, Dr. Tyler served as the Executive Director of Ci3 at the University of Chicago, a research center addressing adolescent reproductive health, and as a director of the Michigan Public Health Institute's Center for Child and Family Health. Dr. Tyler began her career at the Centers for Disease Control and Prevention as an epidemiologist within the Division of Reproductive Health. Dr. Tyler serves on the board of directors for the Society of Family Planning and is the recipient of the 2022 Health and Medicine Emerging Leader Award. She was published in Obstetrics and Gynecology, the Journal of Adolescent Health, Contraception, the American Journal of Obstetrics and Gynecology, among others. Crystal completed her PhD and MPH in epidemiology at Michigan State University and the University of Michigan, respectively, and her bachelor's degree in women's studies at Spelman College. Welcome, Dr. Tyler. We are so honored to have you with us tonight.
Thanks so much for having me. Hey, y'all. Happy Midwifery Week. I'm so excited to be here. Can everybody hear me okay? I can see like 10 faces and everybody's nodding and waving. It's so good to be here. I am Crystal Tyler. I use she, her pronouns, and I'm from Rhia Ventures. I'm going to tell y'all before I get started, my kids will come home within the first 5 minutes of this talk and they will be loud. And although my door is closed and there's a sign that says, please, y'all, give me some peace, they will not do that. So if they burst in here, I apologize ahead of time. You know, kids will be kids. Anyways, so again, I'm so excited to be here to speak with you all today. I'm excited to talk about advancing reproductive and maternal health equity, and I'm looking forward to today's discussion. All right, so first I want to give you some background and context for maternal and reproductive health in the United States. I'm not going to tell you anything that you don't already know, given your field, but it's just helpful to start out with that context. So the current context of maternal and reproductive health says that although we spend more than any other industrialized nation on healthcare, our outcomes in the US are among the worst. Maternal mortality in the United States is actually increasing instead of decreasing, and racial disparities in maternal mortality in the United States are staggering, with an almost threefold higher rate among Black women compared with white women. So thinking about this and experiencing this and living in this country, we also know that maternal morbidity and mortality have received their fair share of media attention. It has been splashed all over the news the past months, the past few weeks. This is partly due to recent studies, which have shown that not only are rates increasing, but also due to the fact that recent studies have shown that about 80% of all pregnancy-related deaths are preventable. And we know that socioeconomic status, education, and other factors that we've historically tried to use to explain away these disparities don't seem to protect Black women in particular for these risks. We also know that factors such as smoking and drug abuse and obesity, the list goes on and on and on, do not explain these differences. So couple this background with the recent Dobbs decision that overturned Roe v. Wade and criminalizes women and other birthing people for accessing reproductive health services. We've got ourselves a bit of a media frenzy on the light side, and we got ourselves a bit of a public health catastrophe on the heavier side. So we know that many of these poor outcomes really are not inevitable. They're really the result of laws and policies and institutional practices that can actually be changed. So a lot of these things are preventable. We can do something about it. but they're also due to a long result of this country's complex history. And what I'd argue is this country's origin story. So before I jump into the bigger picture of what we should do about these disparities and inequities in reproductive and maternal health, I'd like to walk through some of that historical context today and start out with some background on the importance of an origin story. So I'm curious to know, does anyone know who this man is? I'm going to pause. We have a whole hour. I'm going to let y'all guess, and I'd love to see some guesses in the chat. And while you're thinking, I'll give you a little bit of background on me. You heard my big picture professional background, but I'd also like to say that in my spare time, I'm an avid fantasy reader. I love reading fantasy. Oh, these are actually really, really good guesses. And if I just let y'all guess, this is a very good guess. Nope, it's not J. Marion Sims. Nope. It is related to my good guess, C.S. Lewis. It is not C.S. Lewis, but very good guess. Related to my favorite pastime, which is reading fantasy novels. Any last guesses? And while y'all are guessing, I'll say I'm really going to push on this point on the U.S. origin story because I think it's incredibly important and it undergirds many of the inequalities that we see here today. I see love grab. Tolkien. Who is this? Aline? Ding, 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 ding. You got it. It's Tolkien. Tolkien. I say Tolkien. One of my absolute favorite fantasy authors. The author of all of these incredible fantasy novels. For folks who are just light touch fantasy readers, Tolkien wrote The Hobbit and Lord of the Rings. For all of you deep dive fantasy readers, Tolkien actually wrote The Silmarillion, which is my favorite fantasy story. The kids are coming in, they're gonna be loud. Which is my favorite fantasy story. Look, love. Thank you, Kimberly. My favorite fantasy story, and it's actually the topic of this Amazon Prime series that's on right now. And so I don't say this to make light of disparities in reproductive and maternal health outcomes. I bring this up to say that even in fantasy novels, even in Disney, when you look at any fantasy story, they start with once upon a time, and they never start with the person or the topic of the story. They start with their parents. They start with their origin story. They start with the history and context. There is a reason for that. So I will say that for our part, the US has a really complex history with race and inequality, and it's led to a number of the health outcomes that we see today for women and other birthing people, in color in particular. And I'll push on the point that it's really specific to women, and children in particular have most experienced a number of these health outcomes. So thinking about origin story, I'm going to take a pause to share a little bit about my origin story. This is my mom and myself at my first birthday. And I'm not going to tell you what year it is, but you can probably judge by the hairstyle, that crushed red velvet-esque material, the wallpaper in the back, and that might even be one of those old-fashioned stoves. I'm not sure. You can probably guess by this that this was a little while ago. I'm not a 90s baby, I guess is what I can say. And I bring this up to say that when you look at my origin story and my start as a public health practitioner, it really started back a couple generations. And I include my mom here because I was her first child. This was her first time being pregnant, her first childbirth experience, and it was a very traumatic one for her. I'm not going to go into all the detail on her trauma and why that was, but I will say that there was a point in time where they did not know if she was going to make it, and it was tough. It was tough for my mother. It was tough for my father. But thankfully, my mom made it. She wasn't one of the statistics. She wasn't one of the people who didn't make it, and thankfully, I made it. So I put this picture here to show the first birthday is an important birthday. You pass that stage of infant mortality, you're no longer at risk for infant mortality. And I just wanted to put this here, and I will actually come back to this and the importance of an origin story. So thinking about the US and our origin story, it's a bit of a busy figure, but I'll try to walk you through it. So this figure is by Dr. Cynthia Prather, Dr. Talaria Fuller, and others at the Centers for Disease Control. And it presents a time period spanning about 400 years, beginning in 1619, when enslaved Africans were brought to this United States. It includes the time periods of slavery, Jim Crow, the civil rights era, and the post-civil rights period. And again, it goes from 1619 all the way up until recent years, I think maybe 2018. On the far left, you'll see the time period. Next to that, you'll see the actual years and the number of years. Next to that, in the fourth column, you'll see the personal experiences of those who lived during that time period. And in the far right column, you'll see the healthcare experiences of individuals who lived during that time period. So for example, during slavery at the very top, you'll see that some of the experiences or the healthcare experiences of slaves included gynecologic surgeries being performed on Black women without anesthesia. Some individuals mentioned J. Marion Sims, so that's an example of that. These surgeries weren't necessarily conducted to protect these women. They were really conducted to perfect the procedure for other women and other people who might need them. The next row shows the Jim Crow era, which ran from about 1965 on or through 1965, and it includes things like compulsory sterilization, which actually still happens now. Through the civil rights era, which ended around 1975, still continued medical experimentation. It was not consensual, and actually this still happens now. Then looking at the post-civil rights era, which really continues today, there's still unequal access to healthcare and forced medical procedures. I think a number of us remember just a couple of years ago, 2-3 years ago, forced sterilizations at the Mexico border and in Georgia, I believe. So to put this in context, if you think about the history, this United States history, and its impact on reproductive and maternal health outcomes, you'll see that the big, huge turquoise block is slavery. And the larger blue block, that's Jim Crow. That little tiny green block is the civil rights era. And then the small purple block is post-civil rights. So if you look at this country's history, you can see that the bulk of it was really spent in this hard time. And you'll also see that we're not very far removed from the worst. So many of these human rights violations, because they actually are human rights violations when you're conducting surgeries and experiments on individuals without their consent, and their implications on health and well-being can be found in some of the readings here. I mentioned that in my spare time, I love to read fantasy novels. I also like to read up on history and its impacts on health. So if you're looking for really good readings, a number of them are here, and they talk about the US history and implications for health and well-being. So thinking about these human rights violations and their impacts on health, this is really where we came about with the reproductive justice movement. And so the reproductive justice, y'all, these kids are just. So the reproductive justice movement was coined in 1994 by a group of Black women, and it really was meant to look at reproductive health through the human rights and social justice framework. Reproductive justice equally fights for the right to have a child, the right to not have a child, and the right to parent the children we have in safe and healthy conditions. It also pushes for the right to bodily autonomy or bodily sovereignty. Oops, hang on. Reproductive justice as a movement really centers and analyzes power systems, and it addresses intersecting oppressions. So through a reproductive justice framework, we can really begin to understand and dismantle all the barriers that prevent people from living their best lives, all the barriers that prevent people from accessing healthcare and raising their families in safe and healthy decisions. And we can also focus on the barriers that prevent people from making decisions about their bodies and their lives. So this table was actually something that I hadn't seen before until a few years ago, and it was really helpful for me as a public health practitioner to really put the work that I do as a public health practitioner alongside the work of others who are really in this movement and in this reproductive space. So what this table does is it highlights three different fields of work for those of us who are working to advance reproductive and maternal health. and it includes reproductive health, reproductive rights, and reproductive justice. At the top of the table, you'll see those three headers: reproductive health, rights, and justice. Along the left side of the table, you'll see the focus area, the roles, so the types of individuals who work in that space, and then the strategy that each of these individuals work in. So for example, I'd say for reproductive health, which I imagine a number of folks on this call are focused on reproductive health. Yes, yeah, I see some head nods. Yeah, I see some folks who are like, I'm justice, okay. I see that too. So for individuals who really primarily focus on reproductive health, the focus is really on healthcare, service delivery, specifically around accessibility and culturally competent care is usually what we tend to hear. There's very limited focus on historical context and root causes for health outcomes. I think that's key, and that's why I have that in green. In terms of the roles, this would typically include healthcare providers, midwives, researchers, and I added entrepreneurs to this list because as I started in my new role with Rhia Ventures, I realized this entire world of entrepreneurs and investors who are really focused on health, but they tend to focus on it from this reproductive health perspective as opposed to rights and justice. The reproductive rights folks are really focused on the protection and advancement of rights to reproductive health care. So that includes rights to contraceptive care, rights to abortion care, and they generally do this through the legislative process and the electoral process. This group tends to include policymakers and lawyers, and their strategy is really focused on advocacy and litigation. And I spoke a bit about reproductive justice as a movement, but in terms of who typically participates in this process, it's really movement building, organizers, community-based organizations, and their strategy, again, is really focused on movement building. So this is where health equity comes into play. And as you saw, the topic of the presentation was really focused on health equity. And health equity, I'll say, requires collaboration and coordination across all three of these groups: the health folks, the rights group folks, and the justice group folks. All of us really need to work together to advance equity. And so that definition of reproductive and maternal health equity that I'm using when I speak on this presentation is focused on every person having the opportunity to attain their full reproductive and maternal health potential, and that no one is disadvantaged from achieving that potential because of their social position or any other socially determined circumstances. It actively seeks out and removes underlying social advantages and disadvantages, which contribute to disparate outcomes between groups. That's key. There's an actively seeking out and removing. It's active, it's not passive. It's not something that just happens, and it's not just based on good intentions. There's movement there. So now that we've spoken a little bit about the historical context in the US, the next question is, so what is our role as healthcare providers or as reproductive and maternal health providers? And I say our because I tend to consider myself in the health space, health equity space, moving into the justice space, but mostly firmly in the health space. My formal training is as a researcher, so I would say epidemiology, mostly in the health space. So what's our role as practitioners? Whenever I ask healthcare providers, what is your role in advancing health and healthcare? Generally, I get some combination of this response. My role as a healthcare provider is to ensure access to high quality, culturally competent, comprehensive, fill in the blank. But that's generally what folks in the health space consider their role to be. Yes, no, looking like, does that seem? Yep, yeah, okay. So when we think about access to healthcare, access actually has 5 tenets. And it's not just like this vague access, it has really concrete 5 tenets. The first tenet is affordability. Are people even able to pay for the healthcare that you're offering, or will they have to go into medical debt in order to receive those services? It has to do with availability. That means that the healthcare facilities, any healthcare goods, any healthcare services, any healthcare programs must be sufficiently available in all areas. That includes urban versus rural. That includes the number of clinics. That also includes the number of trained medical personnel who are able to provide the services. It means making sure that trained medical personnel have salaries that are adequate to compensate them for their time. And it includes a stockpiling of any sort of resources that you need in those health facilities. All of that is part of availability. When we think about accessibility, it means they have to be accessible to everyone without discrimination. And accessibility, if we're being really specific, so using the Black Mamas Matter Alliance tenets of accessibility, it means non-discrimination. It means physical accessibility. So it has to be within safe physical reach of individuals who need it. It means economic accessibility. So that's partly affordability, but it's also whether it's privately or publicly owned. And cost structures associated with it. The information has to be accessible. It has to be, the information has to be used in languages that's plain, that's clear for people to understand, and that don't have any sort of underlying historical trauma. They're not leading to any sort of underlying historical trauma. Finally, the services need to be acceptable. They need to respect medical ethics, and they need to respect the culture of the individuals who are receiving those services, which means they need to be sensitive to gender and life cycle requirements. Last, in terms of accommodation, it needs to meet the preferences and the constraints of the patient. So this is what we mean when we talk about access to healthcare. So I'm going to go back to this original question. Ensuring access to high quality, culturally competent, comprehensive care. How many of us are doing this? I saw one hand. Yes, yes, yes. Okay. I see some yeses, and then I see some, maybe we could be doing this better. Okay. So moving into the second part, this is part of the title of the talk, and this is something I really wanted to hone in on too. So this concept of doing no harm, this is one of the principal concepts in bioethics. I mean, I took several bioethics courses in school, and this was like the #1 concept. I've also done, anybody do human subjects research? When you think about human subjects research and IRB review, they always talk about doing no harm. Very basic concept. It's a fundamental principle. It's taught throughout the world. The other part of this is not just doing no harm, but it's also saying that it may be better to do nothing rather than to do some harm. You really don't want to risk doing harm. I'd like to argue that this concept of doing no harm is actually not equity informed. The reason I say that is because healthcare, or the provision of care, science, or the new science, innovation, policies, none of these things are neutral. None of these things are apolitical. I would argue that we're either actively mitigating harm, like actively doing something to ameliorate effects, or we are actively contributing to systems of inequity. There is no in between. So this concept of doing no harm, it's not just sort of a passive thing. You're either actively mitigating effects of inequity, or you're actively causing inequity. There really is no in between. I'd also say that this is sort of where those concepts of unconscious bias and medical racism creep in. So this concept of doing no harm and the concept of harm is really focused on the individual. Like if I, as the healthcare provider, or I, as the individual, didn't really intend to do harm, that's really the most important part. And that's not the case at all. So if you predicate health outcomes on the individual, it really provides opportunities for all sorts of issues, medical racism, unconscious bias, all of those things to creep in. And as an aside, as a clinician, your good intentions are absolutely relevant, but they are not sufficient to prevent harm, especially going back to that original point. So I'm going to take a pause and talk about another origin story. I don't know if this would be considered an origin story, but it's definitely a historical context story. So I'm going to talk about Dr. Shalon Irving, who was an epidemiologist at CDC while I was at CDC. She worked in a different division than me, but we were both there at the same time. I'm bringing her up because both of us have similar trainings, both trained as epidemiologists, doctorally trained epidemiologists. Both worked at CDC. I was in the division of reproductive health. She was in another division. Both had children around the same time, both Black women. The list really goes on. And Shalon Irving was, as I mentioned, an epidemiologist at CDC. Her research was actually focused on health disparities. And Shalon actually passed away in 2017, just 3 weeks after giving birth to her daughter. So in the week leading up to her death, Shalon had a number of red flags. She had spikes in blood pressure. She had severe swelling in her legs. She had headaches and swelling at her C-section incision. And she repeatedly sought medical care, not just because she was an individual who was in need of medical care, but because she was an epidemiologist working in the public health system. And she knew, based on her training, that these issues that she experienced required medical care. Every single provider she spoke with in 2017 told her that her symptoms were normal and they dismissed them. Shalon eventually collapsed at home and died. And that was it. That was really the end of it. So even though Shalon had a whole PhD, a whole career as an epidemiologist in the Centers for Disease Control, private healthcare insurance, she's in this Commissioned Corps uniform, meaning she has private and military grade health insurance, a social safety net and a professional safety net of all of the professionals, all of the medical providers around her. That still was not enough to ensure her survival. And I bring this story not to traumatize individuals and not to make light of her experience, but just to say that this crisis of maternal morbidity and mortality is driven by systems and structures, but it's also driven by some of the biases in the medical system. And if we just think about ourselves and our intentions and our intention to not really want to do harm, that's not sufficient. It's not enough. So I'll also bring up in 2016, I'm sure there were other studies since then, but in 2016, there was a study among white medical students, and nearly half of those medical students in that study held false beliefs about biological differences in Black patients, meaning they thought their skin was thicker. They thought that they had less sensitive nerve endings. They didn't feel pain the way other students did. And this was just in 2016, a 2016 study. So this is just to say that when you think about big picture context, when you think about the historical context, when you think about our country's origin story and the origin story of every mother of color or birthing person, all of this plays a part in it. So I'd argue that as reproductive and maternal health practitioners, we absolutely have a responsibility to do no harm, but we also have a responsibility to combat, grapple with, ameliorate, whatever words you want to plug in there. We need to address some of these historic harms, which still manifest today. Knowledge, education, insurance status isn't going to solely cut it. So now that I've given you a lot to think about, I will say, don't worry. I've got a few frameworks here that will help you on your journey if you are interested. You don't have to do this alone. There are very smart people who have thought through this and came up with frameworks for y'all to use. So you ready to hear some of these frameworks? Okay. I'm so happy everybody's on camera, or I can see people on camera. Usually you can't see anyone, so I appreciate being able to see facial reactions. So I've got frameworks for educational and academic leadership, because this is an academic setting. I've got frameworks for organizational leadership. This could be organizational leadership in a nonprofit space, in a hospital space, in an investment space, in a for-profit space. This particular organizational leadership could work across. I've also got frameworks for government and policymakers. I mentioned a little bit about access and healthcare provision earlier, so I don't have a framework for healthcare providers, but if you need another framework beyond that access one, I'm happy to provide it. Just let me know. So thinking about frameworks, has anybody heard of the Equity Agenda Guideline for midwives? Has anybody heard of this framework? I'm seeing, nope. Oh, I see one person who said yes. Everybody else is saying no. Okay. So this framework, it really says that midwifery educational institutions that acknowledge inequities and racism that impact their underrepresented students and faculty can really mitigate some of these inequities and the inequities in the broader healthcare space by following this particular roadmap. It's all been spelled out. So the goal of this equity agenda guideline is to advance and support a diverse midwifery workforce and to advance transformative change regarding equity and social justice in the broader healthcare system. This slide is a little bit busy, but I'm going to walk you through it. And I included, you all will get a copy of these slides, and I've included links to the resources in the slides, so you'll have them here. So in this framework, you can see the core elements of the framework are included in, I guess it's like a burgundy, like a pinkish yellow mauve at the center of the orb. And they include faculty and staff development and retention, and the retention of underrepresented students and students of color. And we want to do this through promotion and tenure for faculty members, but also through scholarships and financial aid and safe and inclusive and affirming learning environments for students. The middle ring, which is kind of a bluish, like a royal blue color, includes curriculum and learning. And that curriculum and learning, it really embeds power, privilege, intersectionality, critical consciousness, and anti-racism. So like hard-hitting, hardcore content for the curriculum, for the students and for the faculty members. It also demonstrates the importance of lifelong reflection and commitment. So it's not just something that you would participate in during school. This is something that you continue to engage in over your professional career. The outer ring, which is kind of like a yellow marigold color, it includes supportive administrative functions and roles. And it includes like statements, so like mission statements for the organization, reviews and planning, and equity assessments for the entire organization. It also includes infrastructure, so staffing and capacity activities, which really hold all the other ones together. And big picture, all of these activities are crucial to develop and support over time, but this framework does not assume that you will do everything at one time. It also gives you suggestions. If you just need to start with one or two, it'll say this is where you should start. Which is also really helpful because no one wants to be overwhelmed by their equity journey. This is a marathon, it's not a sprint. So this is the first one for academic institutions. So the second framework was actually developed, it's an adaptation of a framework that was developed by our CEO at Rhia Ventures, Erica Seth Davies. And it's an adaptation of a framework called the REAL framework. It's the Racial Equity Asset Lab framework. It was originally developed for impact investors or funders in general who were interested in advancing racial equity. So it was initially solely focused on racial equity. What we did at Rhia Ventures was take this framework and adapt it to the reproductive and maternal health space. And we specifically focused on organizations who are working on reproductive and maternal health. So it could be a hospital or a healthcare system. It could be a startup company who's focused on reproductive health, or a nonprofit organization. Anyone who's focused on reproductive health, this framework could support you. Across the bottom or middle, you'll see that the framework is built as a continuum. So an organization can start in this sort of equity blind space, which generally says, like, I don't really understand equity. And my thought around this work is, if I have a product or service and it's good for anyone, it's good for everyone. That's sort of the equity blind perspective. It moves on to a diversity only perspective, which says, you know, I'm working on representation. I have people of color on my team. Check and check, I'm done. That's sort of the diversity only perspective. Then it moves on to an equity tentative, which means that the organization or the individual has some sense of equity, but the policies and practices are really focused on individual change as opposed to the systems and structures. And then the final level, sort of that equity focus level, the organization has this intersectional lens or this intersectional approach, which considers gender and race and sexual orientation. And above all, the equity principles and practices are embedded into systems and structures and policies, not just solely related to one individual. The thought is that so in order to make sure that organizations are able to move from this equity blind all the way across to equity focused, there are indicators. And within each indicators, there are categories. So an organization, so the indicators have to do with things like stated commitment. Do you have a mission or a vision statement that's focused on equity? Accountability mechanisms. Who is in positions of power? Who is able to say, yes, this is what we should do, or no, that's not what we should do? It includes narrative and communications. It's really talking about the way you frame your health, your programming and your work. And across each of these indicators, an organization is able to move from equity blind all the way across to equity focused. So as an organization, you might be at a diversity only when it comes to your data practices, but you might be really equity focused when it comes to stakeholder engagement. So it gives you credit for the things you're doing well, and it lets you know where you need to improve. So this is the second framework, again, focused on organizational practices and procedures. I didn't have this slide up. Can you all, is it? Okay, all right. So these were the equity indicators, and this is that framework. The final framework is focused on policy and government, and it's by the Black Mamas Matter Alliance. This particular framework is really focused on advancing the human right to respectful maternal health care. And it includes a number of components or things that governments or policymakers should do. So for example, when it comes to respect, government should refrain from interfering in a person's access to healthcare or the services they need. When it comes to protect, government should protect third parties from interfering with those rights. And it continues on to fulfill and accountability with respect to government policies and procedures. This framework also includes things that people should have access to. So people should have access to information. They should be able to make decisions. They should have transparency with the information, and they should be able to participate in processes or their healthcare. It also includes things like empowerment, which is really important for women and girls or other birthing people, that they be empowered to make decisions around their bodies. Finally, it includes concepts such as non-discrimination, equity, and universality. So making sure that these things are available to everyone is one of the key tenets for this work. Again, the source for each of these frameworks is included in the slides, so you'll have them. So these frameworks, they included a lot of content, they included a lot of information, but there were a few themes that are consistent across the framework. And I just want to highlight those themes so that you're aware. If we're really trying to advance reproductive and maternal health equity, things that need to be in place, you have to address power dynamics and privilege. If people don't have the ability to make decisions for themselves, if they don't have the power to make decisions for themselves, their health is not going to be, equitable outcomes are not going to be achieved. Each of these frameworks consider historical context and the implications on health today. So if you're providing services and you don't have understanding for that origin story, for that once upon a time there was a mother and a father and they had these children, like, you're not going to be able to achieve equitable health outcomes. They also include an intersectional perspective. So when I say intersectionality, I mean each individual or group embodies external or internal identification across a number of constraints. So they have unique social categories such as race, which intersects with class, which intersects with gender. And each of these categories are interconnected and overlapping. And each of these overlapping and interconnected categories can result in multiple layers of discrimination, disadvantage, or privilege. So someone's intersecting identities can lead to privilege, or it can lead to disadvantage. Finally, each of these frameworks address systems and structures. They're not just focused on individual care, because if you want to advance reproductive and maternal health equity, you have to consider systems and structures. So before I close, I just wanted to talk about one more concept, which I think is really important to mention, and that's this concept of health equity tourism. Health equity has had a lot of publicity in the past few, I don't know, decades, years or so, and which is fantastic. I think it's great. This concept of health equity tourism, I think it was originally applied to research, and it's really the process where previously unengaged practitioners sort of pilot into the health equity space, which is great because we really want people to advance equity, but they're doing it without the necessary understanding of the context, the root causes, and they don't really have the expertise for high quality work. My ask to you is not to do that. Please engage in this work authentically, but also make sure that you're understanding some of the root causes, some of the terminology, some of the research and background that's been done before you jump into this space. And also understand that health equity work requires infrastructure. So you can't just like slap a committee on it without any power and any infrastructure. That's not really going to advance the work. So just an aside on health equity tourism. So in terms of wrap up and next steps, key take home messages are this equity work, it requires someone to address power dynamics. Organizations need to address power dynamics, systems, and structures if they're going to do equity work. Organizations really need to consider the historical context if they're doing equity work. These outcomes don't really exist in a bubble. They're the result of a long history You have to take an intersectional perspective in the work that you're doing. And the equity work needs to be intentional and it needs to be ongoing. It can't just be one point in time, but you have to continue the work. And please, please, please don't be a tourist in the space. Come, learn, engage, stay a while. I think that's it. Thanks so much for your time. I'm happy to answer any questions that you all have.
Everyone, please, you have unmute capability, so please feel free to unmute yourself if you would like to ask Dr. Tyler a question. Dr. Tyler, thank you so much for this very thought-provoking and inspiring presentation to get us all into the movement space. It is much needed and appreciated. Thank you for that. Any questions from the audience? There was a rich discussion in the chat. For those of you who were concentrating on Dr. Tyler's presentation, didn't get a chance to.
I missed the chat.
Yeah, you might want to take a peek. There are some interesting comments before all the thank yous. You scroll up a little bit.
Okay. Oh, good. I'm happy you couldn't hear the kids. They came in.
They
came in.
There was a question, what does delivering people, quote unquote, mean? Delivering people, Dr. Tyler, there was a question. What does delivering people?
I'm not sure. What's the context for the question?
I'm wondering if it's the same as birthing people, but I'm not sure.
Okay. Oh, yes. Oh, so when I said women and other birthing people, is that what you're? Yes. Okay. Yes. So it's just to reference the fact that everyone who gives birth doesn't necessarily consider themselves a woman. So there are trans, gender non-conforming individuals, and I just wanted to be inclusive in the language.
Thank you for that.
No problem.
Let's see, any other questions?
I have a question. Hi, Dr. Tyler. What an inspiring talk. Thank you so very much. I wanted you to sort of piggyback. I love the term health equity tourism. Could you give us an example of how that is used? And if so, how can we combat it?
Yes, I can. Let me just stop sharing my screen so that everyone can see everyone else. Okay, so yes, I can. And I'll say this was really in the research space. It was originally framed in the research space. And what happened was as health disparity talk moved to talk of health equity, there was an influx of funding into this space. And what happened was a number of the researchers who really have spent a lot of time conducting research and study on this topic were sort of pushed out by researchers who came in without any sort of context, no understanding of intersectionality, no understanding of historical context, really just as an opportunity to receive funding. So that's really how it was used originally in research, but it's also happened across practice. Organizations and individuals within organizations who say, you know, I can do health equity work. Yes, I think we are doing health equity work, and just sort of tagging it as health equity without addressing systems or structures. It's not health equity work if you don't have any sort of analysis or work around systems and structures. or doing work but not really considering the historical context, or doing work but not centering individuals who have been most marginalized by historic harm. That's not really doing health equity work well, and it's not really doing it justice. So it's really a push to say, if you're going to do this work, and everyone should do this work, but do your homework and do it well in a way that you would want others to do their homework and do it well if they came into your space.
Thank you.
This is, yes, this is Jill Alleman. I have a question. I'm really fascinated by your figure on accessibility and the idea of, I think it was 5 components of accessibility. And this is something I've thought about over a fairly long clinical career. I'm now semi-retired and doing teaching here part-time. But my question is, can you give some examples of how clinics, care providers, whatever, the care is being provided, how can it be made more, what are some examples of how care can be made acceptable? Because I've always said, you know, just having a clinic down the street doesn't mean the care is accessible. So if you could discuss that a little more and give some examples of some ways that care could be more acceptable to clients or patients. Thank you.
Sure. I'm happy to do that. So for this, I'll give an example of some work that I did in my prior role at Ci3 at the University of Chicago, because we were really focused on adolescent sexual and reproductive health. And so our work was really focused on designing and co-designing, in particular, using participatory design. People have heard of human-centered design, design thinking. So this was really participatory design that we used in order to co-create care for adolescents. And so to answer your question, the short way is talk to individuals who you want to serve and ask them the best way to make sure that they're able to receive care. And so when we at Ci3 spoke to adolescents, we learned a whole, for lack of a better term, no, I'm not going to say that, but we learned a whole gob of information that we really didn't know. We just sat down with them and had them walk through clinic tours to say, like, okay, this is a clinical space. What do you think about this space? They completely changed our frame of thinking. We talked to them about contraceptive methods. They had never seen, like, they were like, oh, I thought an IUD was the size of a football. I didn't know that. I would have never even considered an IUD if you'd shown me this particular thing. And so I think for us as adults trying to provide care to adolescents, our frame of reference is always the adult frame of reference. We had to actually go to them, co-design with them, and make them equal partners in the process in order to understand what they need. So I guess I would say, Jill, to you, it would be a matter of asking the individuals you want to serve. And good public health is local public health. Like, all good policies are local policies. Speak to the individuals in your community to say, how can we best meet your needs? And I think they would best be able to tell you that. Any other questions? And if they're in the chat.
There was a question in the chat, Dr. Tyler. Is there a group organization that can provide assistance to organizations and how to achieve healthcare equity or how they are falling short?
Yes. So I'll say our work at Rhia Ventures, we do this work and we don't charge for this work. I mean, we actively seek out funding from foundations and others in order to support organizations on their equity journey. We tend to focus on reproductive and maternal health. So if you do work in the reproductive and maternal health space, we can support your organization with like an equity assessment and some ideas on where to go next. And we do that free of charge. There are other organizations who I think do work. I don't know what their funding structure is. And so I don't want to say, yeah, talk to them. But it's, you know, every organization has a different funding structure, but we do. And there are a number of other organizations who do this work also. I'm happy to share a list of others that I know of if it's helpful.
Then there's just a comment in the chat box: meeting those who serve on their level will reach more people than assuming that your knowledge is greater than theirs because of your degree level.
Absolutely. Agreed.
Dr. Alexander Delpesh asks, do you do equity assessment for institutions of higher education?
We haven't done them for educational institutions. And if there's interest, we haven't done them, and we haven't adapted the framework for educational institutions. I actually would say, given all of the specifics for educational institutions, I would probably recommend that particular resource that I mentioned in the presentation.
Any other questions? Again, we welcome you to unmute yourself to ask a question. You can also put a question in the chat box. Lots of thank yous for Dr. Tyler sharing her valuable information, time, and knowledge.
Y'all are so welcome. I appreciate, more than anything, I appreciate that y'all are on camera. This is a big deal.
I agree.
No one's ever on camera for these meetings, so I appreciate seeing faces.
Okay, so Dr. Mans James is asking, can I ask a question about service development and ensuring the most vulnerable get equitable care? Sometimes due to issues of scale, there is tension between increasing access to a large number of people quickly and designing service for the most vulnerable who might not benefit from the, quote, fastest route to getting the most people served, quote, model. In organizations that are concerned with equity, this can result in getting stuck in a loop of, quote, can't do X because this smaller and most vulnerable group won't benefit from X, even though a large number of people would benefit. If the goal is get everyone served as quickly as possible, ensuring that the most vulnerable get services needed and we don't stop until we get there, is there a benefit to starting with highly niche solutions that serve a small number of very vulnerable people versus serving a large number of also vulnerable but not as vulnerable people as a starting point? It's a philosophical but also practical dilemma at times.
Yes, I appreciate this question, and we talk about this a lot. I would actually argue that, and there's been theory on this also. I cite theory, but I don't create and design theory. There's theory on this also, and I think one of the most lay language examples of the theory on this would be the curb effect. Has anyone heard of the curb effect? I see some nodding. Okay, so basically the curb effect says, you have sidewalks, and for individuals who need wheelchairs, they sort of flatten out the curve so you can just roll on there and you don't have to step up. Those of us who aren't in wheelchairs, I mean, it doesn't make a difference to us. We can walk up whether there's a step or not, but for individuals with wheelchairs, that makes all the difference in the world. So I would actually argue that if you center individuals who are most marginalized in your care, center those individuals in your care. It's not highly niche to center individuals who most experience disparities. If you center those individuals, other folks will be able to receive the care they need. It's not an either or. And if you don't center individuals who have most been harmed by historical issues, you're going to miss your target. So that's my push, is that generally speaking, center those who most need the care. Other people will be able to receive the care either way.
Thank you so much for that. Let me see, there's a comment that there's a thought that you'd be an amazing asset to partners in health organization. And there's a question about you sharing the framework for healthcare providers that you mentioned earlier.
Mm-hmm. Yes, I can. It was really focused on access for healthcare providers. That's really where I pulled a lot of that information. Do you all want an additional framework for healthcare providers? Because I can send that too. I don't have it readily available, but I can send it. Yep.
We would love to read it all. We're all very excited by this.
Okay.
There is another question. There are many providers who are waiting to better understand how to do no harm and who don't know what their knowledge deficits are. I believe that healthcare students is a great place to begin prior to them going into the clinical setting. I educate them about implicit bias and the effect on the delivery of healthcare. So I guess not so much a question, but if you had any comments about that.
I think that's fantastic, and I'm happy to hear it. Oh, also pushing on them to continue their learning, because it's not just a one and done.
Yeah, thank you for that. Any other questions? Right. We're just about done here. I want to take a moment to again thank you and applaud Dr. Tyler for her amazing presentation tonight. I think we all have a lot to think about moving forward as educators and practitioners and change agents in the world. So I hope all of you found you got something out of this somewhere along the way. I'm sure you did. Again, Dr. Tyler, so encouraged by your presentation and just so thankful that you could spend this time with us. We had an amazing turnout, and I think that speaks a lot to your reputation and the important work that you're doing. So again, thank you so much for your time.
Thanks, y'all, so much for having me. I hope you'll have a fantastic rest of the week. Cheers to everybody.
Yeah.
Bye.
Thank you. Bye.